The psychology of back pain. Everyone knows back pain consults are difficult. In one study, it was the second most hated presenting complaint, with back pain patients waiting 25% longer than matched controls due to doctors cherry picking around them. But what makes back pain difficult? The medical knowledge part of it is easy enough. It is the psychology that makes it hard. That is what we're going to focus on today. Say this is the rational part of the patient's psyche that you want to talk to, and this is you over here. What's stopping you from getting there? First, they might not entirely trust you in the same way that you might not trust a first quote from a tradesman you just met. And secondly, emotion. It has been said that the emotional tail wags the rational dog. That is, the emotions are really in charge. So let's start with these. The easiest thing is to treat the pain. A position of comfort, aka position of least pain, for instance, the Z position, and medications. We'll skip the detail on this because we don't want to, well, you know. And empathy can help with pain too. One study showed physician empathy was better for both pain and function in chronic back pain than non-pharma treatments like massage and acupuncture, as well as opioids and surgery. And it just so happens to be the best thing for building trust and calming emotion. Obviously, the way to learn empathy is to start with a comprehensive analysis of all the definitions and subtypes. Joking! Is it even possible to train to be empathetic? People debate this. But what we do know is this. Socially, a cockroach, or in this case a little rudeness, will ruin a bowl of cherries or niceness. But a cherry won't do anything for a bowl of cockroaches. That is, it is much more important to avoid the bad than to do good. Here are some examples. Of course, no one goes to work planning to do any of these things. So why do they happen? A lot of the same factors that cause error can contribute to low empathy. Time pressure, frustration from recent conflict, hunger, tiredness. So sometimes looking after yourself is the best thing to do. And as far as time pressure goes, it can be really tempting to talk slightly faster during a consult or interrupt more than necessary. But how much time do you really save from this? Maybe 30 seconds. But then you might lose 30 minutes later on because the patient's too upset, so they progress less quickly and need more attention later. It can sometimes be really hard to empathise with patients on the occasions that their emotions seem way out of proportion to the situation. Medical practitioners tend to be from the water tribe, and back pain patients can sometimes be from the Fire Nation. So for once, the calm that makes you good at your job can be a disadvantage, as it can make it hard to empathise with the incredible intensity of feelings that back pain patients sometimes have. If you find this, one thing you might be able to do, even if you can't really imagine yourself in the patient's position, is imagine someone you love being in that state, as a patient in the ED, and how grateful you would be if their doctor was patient and kind to them, and able to calm the situation. So try to be that doctor for someone else's loved one. Okay, let's move on to this part of the patient's psychology. What does a bad mindset look like when it comes to back pain? They might believe that the path to recovery involves a scan to get a specific diagnosis that will lead to specific treatment. They worry about the possibility of serious disease, they see pain as a sign of harm, and don't stay active. And of course, these things all feed into each other. Worry about serious disease leads to wanting to medicalise everything, and that pain is a sign of harm, which makes people shy of activity, and this in turn reduces recovery, which strengthens the cycle. To top it off, if they do manage to wrangle an MRI, what is the most likely outcome? False positives, specifically degenerative disc disease, which a fair amount of asymptomatic 20-year-olds have, and the vast majority of anyone over 50. Also, what is asymptomatic degeneration? It is aging. So calling it a disease is like calling wrinkles degenerative face disease. So what did the anxious patient with back pain who is trying to stay positive get for Christmas? An MRI result showing degenerative disc disease. And conversely, what does a good mindset look like? Recovery is natural, their back is okay, pain is not a sign of harm, activity is good. Which also all turns into a positive feedback loop. Natural recovery is reassuring that their back is okay, which reinforces beliefs about pain and activity, which again promotes recovery. It's about control. In one case, the patient is in control, and in the other, the medical system and fate is in control. And we really need to make sure the patient leaves with some sense of control. But what do doctors naturally do? We consider serious pathology first. Worst things first, right? And we love tests and diagnoses and treatments. So we can accidentally over-medicalise back pain. Of course, we still need to rule out red flag conditions, but with back pain, we need to do it in a really tactful way that keeps reassurance front and centre to make sure we are nudging the patient left rather than right. Let's go over some key messages for people with back pain. Your pain will settle. Most people make an excellent recovery. This is a focus on optimism, and you can say that thing that 95% of people are better by 6 weeks, which helps to manage expectations. As bad as your pain is, you don't have a dangerous condition of your back, which validates their suffering and also addresses the common idea that bad pain must equal a bad condition. Movement won't cause harm, staying active will help your recovery. This points to the idea that they're in control with staying active. Pain relief can help a little, but can cause problems. A scan is not going to help at this point and can sometimes make things worse. Both of which I'd only discuss if it was relevant, for instance if the patient was pushing for opioids or an MRI, and by that stage they need some more details around pros and especially cons. For opioids, I try to explain opioid-induced hyperalgesia, and for MRIs, I try to explain the problems with false positives. So back pain is hard, but remember, the patient is the one with the disease. That is, having back pain is way harder than treating someone with back pain. But if you're good at it, you can take a huge amount of morbidity off the patient, which is a worthy thing to do. Bye!